Welcome and Happy New Year. I am your host, Susan Ward, and I'm here in my capacity as an ambassador for the Family Heart Foundation and a moderator for the lipoprotein A support group. I'm also a nationally board certified health and wellness coach and lifestyle coach for the CDC National Diabetes Prevention Program. I live in Montclair, New Jersey with my husband, and I have 3 daughters. Tonight, we're going to continue with our mission, Empower Lipoprotein A. And this is the first of our series this year. Our lecture tonight is titled Beyond Genetics, the Interplay of Lifestyle and Lipoprotein A in Cardiovascular Health. And our special guest is Professeur Benoit Arsenault de le Département de Médecine, Université Laval, Quebec, Canada. And that's all the French are going to get from me tonight. But he will be presenting. And in just, I want to just go over a few housekeeping items. Please put your intro into the chat feature at the bottom of your dashboard, where you can put something about where you're from, as well as something you'd like to share about your LPA journey. Please keep yourself on mute and your video off during the presentation. When we start the presentation, you are welcome to put a question in the chat, please, 1 per person, because we have a large group tonight, and we certainly want to get to all your questions. And first, I'd like to read our medical disclaimer. Today's program is for your informational and educational purposes. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, nor does your participation constitute a medical or coaching relationship with the presenters or employees or officers of the Family Heart Foundation. Information in this presentation may be updated or changed in subsequent presentations. Follow up with your medical professional for specific recommendations pertaining to your or your family member's diagnosis or treatment. Reach out to a Family Heart Foundation care navigation specialist for further resources. And that link is right here, and we'll put it into the chat. And this is for anyone that's looking for guidance in finding a doctor, in finding a lipidologist in particular, in getting your family members tested through the Cholesterol Connect program that has been launched, and just to have help beyond what the support group can give. So Empower LPA support group meetings started last year, and aligned with the mission of the Family Heart Foundation, we promote research, education, and advocacy. We hosted monthly meetings with guest speakers and Family Heart ambassadors, and our topics included the science of Lp(a), research and trials, diagnostic tools, and dietary considerations. We started out with Eric Tricou, who is a Family Heart Foundation care navigator and a genetic counselor. We had nutritionist and clinical lipid specialist and Family Heart ambassador Heather Shasa. We had the former chief medical officer, Dr. Mary McGowan, who spoke to us about diagnostic tools, in particular the imaging tools and when they are used. We had Dr. Robert Fishberg, who actually is my cardiologist and lipidologist here in New Jersey, who spoke about the research and the trials that are ongoing right now. And as a series highlight, we did have a wonderful series with Dr. Thomas Dayspring, who is certainly quite famous as a lipidologist and educator, who provided us with a series of 3 lectures on Lp(a) treatment, advanced issues, and I always like to say that that particular lecture was Kringle all the way, because we got to see all about the isoforms and the Kringle repeats, and it was really fascinating. And he also gave us a lecture on potential therapeutics. And then Roger Zellner and I, both coaches and family heart ambassadors, developed a pilot program called Dealing with a Diagnosis of Elevated Lp(a) with the support of family heart team members Jen Farnell and Eric Tricou. The program emphasized self-efficacy and advocacy tools to help people, starting with their diagnosis, their reaction, and moving toward the acceptance of medication and treatment and the drive to take care of themselves and their health. I want to, for a moment, just introduce Jen Farnell, who is the Community Activation Manager and from the Family Heart Foundation, and she is the one with whom I plan and helps produce this wonderful series. She is oversees all the ambassadors and the community at large. Jen, could you just say a few words?
Sure. Thank you, Susan. Hello, welcome everybody, and I'm glad you're here tonight. My name is Jen Farnell. I am the Community Activation Manager, so I am thankful to be able to work with all of our Family Heart ambassadors and with all of our community members and volunteers. I have been with the foundation for the almost past year, but I've been involved with it for the past 7 to 8 years. I have FH and elevated Lp(a), and I have 2 children that have been diagnosed with FH also. They're adult children. So thank you and welcome. Thanks, Susan.
Yes, and of course on the right there we have our lovely lipoprotein structure, and we want to mention that on this call tonight we did have 58 people who actually pre-registered, and they are all members of the support group itself. And the balance of the people it's a very, very interesting group because most of them all have, like Jen and myself, lipoprotein(a) that is elevated. We have people that in the support group right now, we have 3,800 members, and it is growing. 28 new members just this past week. And we think about this in terms of the exponential growth that we can expect when 1 in 5 people, 20% of the human population, many of whom have not yet been tested, may want to avail themselves of the help. And so of these members, the 3,800, they're from all over the world, many from the United States and Canada, Australia, UK, Ireland, you name it. They're joining us all over the globe because they want to learn more about this biomarker. So tonight we had about 18 Canadians from various provinces and 1 Quebecois who now resides in Texas, and 2 of them are sisters. We have 16 men, 2 of whom are brothers. We have about 40 women, and 22 who attended our recent series dealing with a diagnosis. And 26 people are new, most of whom just joined in the last 3 or 4 months of 2024, as recently as the day before Christmas. So we have quite a few new people here, and we would really like to make sure that you get a lot of mileage out of this program, and also look up the programs that we've hosted before and watch the videos and look at the slides. And now I have the distinct honor and pleasure to present our guest speaker, Professor Arsenault. He joined the faculty of the Department of Medicine at the university in 2013. He is a full professor. He is also a research scientist in the cardiology axis at the Quebec Heart and Lung Institute. His team uses genetic tools such as Mendelian randomization and family studies to investigate the causes and consequences of cardiometabolic disease, such as non-alcoholic fatty liver disease, dyslipidemia, and type 2 diabetes, and cardiovascular disease. He also leads research programs funded by the Canadian Institutes of Health Research on the identification of therapeutic targets for cardiometabolic disease and on the basic and genetic mechanisms through which the PCSK9 and lipoprotein(a) contribute to heart valve disorders such as calcific aortic valve stenosis. Professor Arsenault holds a Senior Scholar Award from the Fonds de Recherche de Québec Santé, and the research is also funded by the Foundation of the Quebec Heart and Lung Institute. He is also the co-president of the Quebec Society of Lipidology, Nutrition, and Metabolism, and he's authored or co-authored more than 190 peer-reviewed manuscripts. Areas of special interest include genetic epidemiology, Lp(a) lowering therapies, calcific aortic valve stenosis, and atherosclerotic cardiovascular diseases. So with that, I'm going to stop sharing my screen and bring in our guest. And I'm going to ask everyone else if you could turn your videos off so that while we are doing the presentation, we can just see and hear Professor Arsenault. And I just want to say welcome again. We are very honored, and it is our great pleasure to have you with us tonight. And as I asked you in an email, what motivated you to research lipoprotein(a), you said that you would be discussing that from a personal and scientific level. And my other question was, and I know you're going to discuss this too, although we're talking about beyond genetics, don't we as individuals need to first know more about our unique blueprints, the panoply of other risk factors that may complicate or act synergistically with Lp(a) to produce the risk of ASCVD? So with that, we're going to turn off our videos, folks, and let Benoit have the stage.
Well, thank you very much, Suzanne. Thank you, Jen. Thank you to the FH Foundation for this wonderful invitation. Thank you, Suzanne, for the very kind introduction. Very happy to be here tonight with you to discuss a little bit of my personal journey, as Suzanne mentioned, with elevated LPA. So my presentation is entitled Beyond Genetics, the Interplay of Lifestyle, Lipoprotein, A, and Cardiovascular Health. So this is my disclosure information. So I'm just going to start briefly by highlighting the lipoprotein A particle structure. I know most of you are familiar with it. However, I thought it would be interesting just to present it rapidly, just so that everyone is up to speed with what actually represents a lipoprotein A particle and why is it so atherogenic, why it contributes to so many cardiovascular diseases and aortic valve stenosis. So first of all, you see an LDL-like particle. So LDL particles are lipoproteins. They carry cholesterol, triglycerides, vitamins, and other hydrophobic molecules in the bloodstream. Every LDL particle in the circulation has one apolipoprotein called apolipoprotein B100 attached to it. And some LDL particle carry a little bit of oxidized phospholipids that contribute to cardiovascular disease. However, the overwhelming majority of OXPLs or oxidized phospholipid molecules are actually transported by lipoprotein A. So lipoprotein A is an LDL-like particle. It includes the spherical molecules of similar to LDL. It has the ApoB attached to it, but there's another apolipoprotein called apolipoprotein A that's bound to the ApoB100 by some interactions such as the disulfide bridge here. So many of you are familiar with the fact that apolipoprotein A or LPA is a genetic risk factor for atherosclerotic cardiovascular disease. It is formed by what are known as Kringle 4 isoform. And one of the reasons that Kringle 4 type 2 isoform here is highlighted is because they vary very significantly from one individuals to the other. So a majority of the population have several repeats of the Kringle 4 type 2 isoform. Some have up to 40 and even 50 repeats of this part of the apolipoprotein little a and have low Lp levels. And there's about, depending on ethnic backgrounds or the population that you look at, maybe 15 to 25% of the population that have a low amount of Kringle 4 type 2 repeats, and this is associated with elevated lipoprotein little a levels and an increased cardiovascular risk. And one of the reasons that exposure to elevated LPA particle concentration is actually atherogenic is because there are some oxidized phospholipids that also bind to another part of the ApoA molecule, which is called Kringle 4 type 10. That is where most oxidized phospholipids are bound on lipoprotein little a. So ApoA and lipoprotein little a are much more atherogenic than LDL particles. So there's a lot of individuals that have elevated LDL that don't have necessarily signs of atherosclerosis or will never develop cardiovascular disease. Whereas there are some people that have high LPA that may be at even higher cardiovascular disease risk. So on a per particle basis, LPA is much more atherogenic than LDL particles. And this is an analogy that I like to use a lot when I talk to patients or primary care doctors about LPA. So I compare it with I compared LPA to LDL by using this baseball analogy. So in that analogy, well, an LDL particle could be as dangerous as a baseball, basically. So you know that if you get hit on the head with a baseball, obviously it won't feel good. You'll be hurt. You'll have to go to the doctor. But if you get hit by a medieval flail on the head, and in that analogy, that's akin to LPA, then you might come into bigger problems. So on a per particle basis, LPA is much more atherogenic than LDL particles. So I won't discuss the results of genetic study. Although I would like to, I think just for the sake of the presentation, I just want to highlight the fact that that on a per particle basis, LPA, based on very recent research, we know that LPA on a per particle basis is 6 times more atherogenic than LDL particles. So this is a study out of Sweden, I believe, that look at the genetic effect on ApoB on the risk of coronary heart disease, whether the ApoB is transported by an LDL particle or an ApoB is transported by an LPA particle. So both LDL and LPA particles each have one ApoB molecules around it. So from that study, we were these individuals were actually able to show that, well, although LDL particles are much more abundant than LPA particles, especially in patients with familial hypercholesterolemia. And especially in FH, they carry the greatest proportional effect on overall cardiovascular disease risk. However, on a per particle basis, LPA is about 6 times more atherogenic than LDL particles. So people with very high levels of LPA are at very high cardiovascular risk. And in people that have the highest level of lipoprotein little a, well, their risk of cardiovascular disease is actually similar to that of people with familial hypercholesterolemia. So basically, this will be the outline of the presentation. I just want to briefly mention how personally I got interested in lipoprotein little a research. Then I'll tell you a little bit about my background as an epidemiologist, as a genetic epidemiologist now, about the interaction of LPA with lifestyle risk factors and cardiovascular disease risk. And also, I'd like to talk about LPA and calcific aortic valve stenosis, which is what my research currently focuses on. So first of all, I'd like to tell you about this study. So this is the Quebec Cardiovascular Study. This is a paper that was published in 1998. So basically a long time ago, almost 30 years ago. Basically, the Quebec cardiovascular disease, the Quebec cardiovascular study was initiated here in Quebec City in the 1970s. It included more than 2,000 French Canadian men. And while in that cohort, believe it or not, lipoprotein little a was not found to be an independent risk factor for ischemic heart disease. And this is just one example of a plethora of similar studies published in the 1990s that did not find an association with between LPA and cardiovascular disease risk. So as many of you know, LPA was identified, was first characterized actually in the 60s and in the 70s, and in the early 80s, there's been many studies showing association between LPA and the risk of heart disease. But in the 1990s, there were bigger studies with more power that could not replicate this association. So basically, nobody talked about LPA for somewhere between 10 to 15 years in the 1990s and in the early 2000s until genetic papers were actually published looking at lipoprotein little a, and these genetic studies really resurrected the field of LPA research. So this is a paper from Florian Cronenberg and Gerd Utemann from Austria. And I remember reading this paper in 2013. So that was actually when I started my research career as an independent investigator, and I was interested in lipids. I was interested in cardiovascular prevention, but I was not interested at LPA necessarily because of the results of the Quebec cardiovascular study and the other studies showing, well, LPA is difficult to measure, it's complex, the data are not very clear. Nobody knows what it's really doing. Nobody knows if it's actually a risk factor or just a biomarker, or we don't really know. And during that moment, I was actually a postdoc. So I did a couple of postdoctoral fellows, one in Amsterdam at the Academic Medical Center, and another one in Montreal at the Montreal Heart Institute. And basically, I had 3 projects. So the first one was to identify risk factor for recurrent CVD events in secondary prevention. So in patients with documented, with stable coronary artery disease, I was interested in testing the association between dozens of blood-based biomarkers and the risk of recurrent events. So people who had multiple cardiovascular events. So we looked at glucose-related biomarkers, insulin, inflammation, thrombosis, etc. And actually, LPA was one of the strongest risk factors for recurrent cardiovascular events in this cohort. And then I went on to study genetic risk factors for cardiovascular disease, and we were particularly interested in identifying genetic factors that explain LDL response to statins. So basically, in people who are treated with statins, Some have very profound reductions in LDL cholesterol levels, and some have very little, and some even don't respond to statin therapy at all. So we were interested in identifying genetic factors that associate with statin response. And we've actually found that LPA was the top genetic locus for LDL response to statin in a very large genetic consortium called the GIST consortium. So we thought that was an interesting finding because, well, and at the time, and we thought that since LPA is not necessarily influenced by statins, but it's actually included in the calculation of LDL cholesterol levels, then that might be one reason why LPA is a genetic, showed a genetic sign for LDL response to statins. So that was my time in Amsterdam, and then I moved to Montreal, and I was actually interested in the genetics of calcific aortic valve stenosis. And at the time, a colleague from a couple blocks from the Montreal Heart Institute, George Tanasulis at McGill University, actually reported for the first time a strong and independent signal between LPA and aortic valve calcification, and we replicated that finding as soon as we saw it. So the next year we had published our investigation in the Montreal Heart Institute cohort. So that's how I got interested in LPA research. So actually all the signs were there, and that was towards the time that I was launching my own lab here in Quebec City. So given that this re-emerging risk factors was identified by all these independent and hypothesis-free studies, then I took it as a sign that I should actually move into the LPA research field. And one of the reasons that I was actually interested in LPA was after I did my my own genotyping of my own genome. That was at the end of the year 2000, so around 2008 or 2009. There was this company in California that I thought was really interesting because they wanted to find new therapies for several human disease, and that was a citizen science based project. And what I liked is that you can actually send them your saliva, and they obviously report back a summary of your finding, but at the time they could send you all the results in a text file, such as the one that you see here. So the first thing that I did was actually to see if I was a carrier of an LPA rising allele. So you see here, this is a single nucleotide variation. This is one SNP, and this SNP is one of the strongest SNP associated with high LPA. And so my genotype here was AG. So if you have a G allele, then it means that there's approximately 7 to 8% of the population that has a G allele, and it's actually associated with high LPA. So I actually got my LPA tested, and it came back at 200 nanomoles per liter. So that would probably place me at around the 90th percentile of the LPA distribution of the general population. So I'm one of the unlucky people that have elevated lipoprotein little a levels. So I didn't really know what to do at the time when I got this result. I didn't do actually anything for many years until I actually saw the Canadian guidelines. So this is the Canadian the dyslipidemia guidelines from the Canadian Cardiovascular Society. So I've never had a heart attack, so that means that I'm in primary prevention. And I calculated my Framingham risk score. So I had my LDL done. I look at my blood pressure, other behaviors such as smoking. I don't don't have diabetes. However, the Framingham risk score actually put me in an intermediate risk category. And actually, the Canadian guidelines also mention that in individuals that have either high HSCRP, coronary artery calcium, or an LPA above 50 milligrams per deciliter, or over 100 nanomoles per liter, then they should discuss health behaviors with their doctors. And if everything is fine in terms of health behaviors, then they are actually encouraged to initiate statin treatment. So basically, that's what I did. And in Canada, actually, this is also again from the Canadian guidelines. So it is suggested that LPA should be measured at least once in a patient lifetime with initial screening. And we see more and more guidelines, such as this one around the world, suggesting that LPA should be measured at least once in a patient lifetime. So for those of you who want to be more familiar with LPA and you want to hear about the latest research, so this is a scientific a consensus statement actually from the European Atherosclerosis Society that I had the pleasure to co-sign here with Florian Cronenbergs, the genetics guy, and Samia Mora and Eric Struess, and a bunch of other investigators, mostly from Europe. So you can find some information there that's, I think, very interesting. That may be interesting to some of you. But the reason I'm highlighting this paper is that we performed some new analyses in that cohort looking at UK Biobank data. So this is the UK Biobank is actually a very large data set of individuals from the United Kingdom. There's actually close to 500,000 individuals that have been followed now for more than 10 years, and some individuals that have been followed for now up to 20 years. So in that study, what we did is we calculated their baseline risk of ASCVD events. So ASCVD is for atherosclerotic cardiovascular disease, and as a function of LPA plasma concentration. So you see here, so if you look at the blue line, at the blue lines here, you see that in people with low LPA levels, well, the risk increases with the number of risk factors. So the higher the number, the risk factor, the higher the risk of ASCVD events. But look at the effect of LPA on that risk. So you see that even in individuals on the left here that don't have or have very few risk factor, LPA still contributes to elevated risk of ASCVD events. And if you combine both risk factor algorithms such as the Framingham risk score and add the LPA concentrations to it, then you see a very, very high increase in the risk of ASCVD events. So basically what this tells you is that, well, if you have high LPA, you definitely need to target other risk factors for cardiovascular disease, because as I've mentioned earlier, LPA is a genetic risk factor for ASCVD. There's really not much you can do in terms of lifestyle to actually reduce LPA, if anything at all. But some of you may have some power over other risk factor for cardiovascular events. So what I did with my LPA, and this is what we put forward in the EAS consensus statement, is that we advertise this website here, which is called lpaclinicalguidance.com. So basically what I did there is that I entered all the information about my risk factors for ASCVD. So I entered my age, my LDL, body weight, whether I'm a smoker or not. I'm not. I don't have diabetes, and basically some other risk factors. And then they can tell you your cumulative risk of ASCVD events in the presence or absence of LPA. So over the year, my risk would be 26.4% if LPA was not added to the algorithm. But if you factor in my LPA levels, that would mean that my risk of ASCVD events from 40 to 80 would be almost 41%, which is quite elevated. So when I saw that, I actually decided to take a statin. Well, first I had to convince my doctor to prescribe me a statin, because many are very reluctant to do so because they don't know anything about LPA. So this is my LDL before and after the initiation of the statin. Luckily, I was a pretty good responder to the statin. So my LDL went from 3 point something to 1 point something. The ApoB went down. Also, my triglycerides went down quite significantly, which is a bit unexpected, but I'll take it. And the LPA did not change at all with the initiation of the statin. So with my new results, I actually went back to the LPA clinical guidance, and they actually added a new line, which is the light blue line here, that considers my new LDL. So the light blue line actually considers the LPA, and it considers the statin treatment. So simply by taking a statin, by reducing my LDL, which means that I am reducing my overall ASCVD risk, I was able to lower my risk from almost 41% to almost 17%, which is not obviously zero, but it's still quite an interesting reduction. So I was pretty happy with that. Okay, so now I want to talk a little bit about lifestyle risk factor, because although we're all here to learn about LPA, well, LPA is one risk factor. Although it's causal, it's independent, it's dose dependent. It's dose dependently associated with the risk of long-term ASCVD events. Well, LPA is one of many risk factors that are associated with the risk of heart attacks, such as diet, physical activity, tobacco, sleeping habits, body weight, blood lipids, blood glucose, and blood pressure. So and this is what the American Heart Association refers to as life's essential 8. So they basically ask the general population and the family care doctors and general practitioners to assess these behaviors and these health factors, and try to keep them all in the green zone. So you see it here. If I just talk about nutrition, what the AHA would mention is that, well, obviously we should exercise. We shouldn't smoke tobacco or anything else. We should get some healthy amount of sleep, control our lipids, control our blood pressure, our blood glucose, not have an elevated body weight. And here they also mention that we should create a healthy eating patterns, enjoy vegetables, whole grain, beans, legumes, nuts, plant-based proteins, lean animal proteins, skinless poultry, fish, and seafood, and limit sweetened drinks, alcohol, sodium, red and processed meat, refined carbs, and etc. And they also mention some tips for success here. So basically, in terms of research, we were actually interested in whether LPA actually predicts the risk of cardiovascular disease in patients that do everything right and in patients that don't do anything right. So we actually went to the EPIC Norfolk study, which is a very large population study, again in the United Kingdom. So that was before the UK Biobank era. And we actually calculated a cardiovascular health score. And we so individuals with a HUN-LT score were those who were smoking, who were overweight or obese, had diabetes, hypertension, high cholesterol, were sedentary and had a unhealthy diet. So and we looked at patients who had intermediate cardiovascular health score and those who had a healthier cardiovascular risk score. And we identified thousands of individuals in that cohort with elevated LPA levels. And we found that despite having an LPA level that was elevated, while the risk was actually cut by 2/3 from going to unhealthy lifestyle risk factors and clinical risk factors to healthy lifestyle risk factors. Obviously, this is an observational study that we did not do an intervention. There's some limitations to these kinds of studies, but basically what this study suggests is that there's probably an interaction between LPA and lifestyle and clinical risk factors. So, and we should stop saying that if we have high LPA, then there's nothing that we can do, because there's a lot that we can do to mitigate the risk associated with high LPA. So if we don't control aggressively both clinical and lifestyle risk factors, the risk will be there. That will obviously not bring the risk to zero, because there's still some residual risk associated with high LPA in those individuals that do everything right. But I think this was a nice proof of concept that, well, first of all, we need to mention that there's something that we can do if we have high LPA, and it's fine to develop therapies targeted against LPA to reduce LPA and to reduce LPA associated risk. But if we don't do other stuff, if we don't address lifestyle, if we don't address other clinical risk factors, then these new LPA inhibitors might not reduce the risk of cardiovascular disease that much in these individuals, if the ongoing studies, of course, are successful. So we did a little summary of the literature here, basically looking at two different or many different case scenarios. So you have on the top of the slide here individuals who are insulin sensitive, who are physically active, individuals with a healthy dietary pattern that don't have that bad intra-abdominal fat accumulation. So because, well, there's obviously some limitations to body weight or the body mass index as an index for a healthy body weight. So it's really the waist circumference and the fat that's located in the abdomen that is causing a lot of trouble to cardiometabolic health. So in these individuals, they have no liver fat accumulation. They have a normal secretion of VLDL particles, a smaller amount of remnants, and in individuals with normal cholesterol. I need to apologize here, because this was meant to be LPA and not necessarily LDL. Well, it's the same for LPA and both LDL basically. So if you have if you are metabolically healthy, then of course in people with high LPA and normal to high LDL, then there will be high risk, and if you add lipid lowering therapy, then the risk will be reduced. Now at the bottom, in individuals who are insulin resistant, who are sedentary, have an unhealthy dietary pattern, Then there's a lot of intra-abdominal fat accumulation. And unfortunately, this type of adipose tissue, the organs that actually store the fat, can become dysfunctional. It can release free fatty acids in the bloodstream. It can release some very pro-inflammatory hormones that are called adipokines. And this can lead to liver fat accumulation and inflammation in the liver. And this can lead to a very high or increased production of triglyceride-rich VLDL particles. So in the absence of LPA, that can be associated with a moderate risk, but in patients with very high LPA and those small dense LDL that accompany this metabolic state, this could be these individuals could actually be a time bomb for atherosclerotic cardiovascular disease risk. And if you put them on a statin, well, that's fine. Their risk decreases, but it still remains very high because of the poor cardiometabolic health. So let me switch gears a little bit, and for the rest of the presentation, if I may, I'd like to talk a little bit about my research in the field of calcific aortic stenosis. This is a cartoon that I picked up from a review article that I wrote with a colleague of mine from Copenhagen, who did the Copenhagen General Population Study. And actually, we look at the effect of LPA on different cardiovascular disease, such as myocardial infarction, calcific aortic valve stenosis, heart failure, ischemic stroke, peripheral arterial disease, cardiovascular mortality, and also all-cause mortality. And we found that LPA was strongly associated with all of these outcomes. But the outcome that was more influenced by exposure to elevated LPA levels was actually calcific aortic stenosis. So there really seems to be something, because LDL, for instance, it does predict calcific aortic stenosis. It predicts myocardial infarction, but for calcific aortic stenosis, LPA seems to be a much more robust risk factor for this heart valve disorder. So recently, I told you about the study of my colleague George Tanasulis, who looked at the effect of genetic association with valvular calcification and high LPA, found that there was this SNP associated with high LPA that was linked with valvular calcification. So that was the first evidence that we have from the first, actually robust evidence that we had in terms of a signal between LPA and calcific aortic valve stenosis. And as I mentioned earlier, so I told you about my my SNP here, the RS104-55872. And if you have a G allele, then you have a very high risk for aortic valve stenosis. Actually, if you compare individuals who are AA compared them to GG, well, the risk of aortic stenosis, it still remains low in terms of absolute risk. It's only 2.9% of the population, but that does lead to a very high, almost five-fold increased relative risk of calcific aortic stenosis. So we really see this dose-dependent effect of high LPA on calcific aortic stenosis. So I think this is an interesting findings. We also had LPA measured in this cohort, but we thought it would be interesting to look at the genotype as well. We did not find any evidence, not only for calcific aortic valve stenosis, but also for cardiovascular disease, that there is an added value of assessing LPA SNPs. If you have your LPA levels measured, that's probably fine. Although we definitely need more research in that area. There's really no convincing data out there suggesting that there's an added value of genotyping these SNPs over and above an LPA measurement, but still, for this research purposes, it was obviously interesting to look at. I'm going to go very briefly over these slides because I think it's interesting to actually mention that because I get this question asked by cardiologists all the time. They want me to answer whether there's a direct causal link between LPA and calcific aortic valve stenosis that's independent of the presence of coronary artery disease, because in individuals with coronary artery disease, well, in individuals with aortic stenosis, half of them actually have CAD. So in that very big study of 7 US and European cohorts, we found that the risk associated with high LPA was present in patients with CAD, but it was also present in patients that did not have coronary artery disease. So there really is a specific effect of LPA on aortic stenosis risk. So this is the image of an aortic valve. You see it's kind of looks like a Mercedes sign. So the aortic valve is a tri-leaflet valve that you see here, and we actually used in the general population, we used radio tracers such as 18F. So this is sodium fluoride, and we looked at PET CT. So whenever there's some yellow that appears, so it means that the aortic valve actually fixes the sodium fluoride, so it actually tells us where the minerals are present in the aortic valve. So even if there's no evidence of a presence of overt macrocalcification, then in patients with high LPA, we already see signs in healthy individuals that there is an osteoblastogenic process that's ongoing, meaning that in many individuals, the aortic valve actually starts to mineralize, and that can lead to aortic valve stenosis. LPA also not only is associated with the initiation of aortic valve calcification, but it's also linked with progression of aortic valve stenosis. So this is data that was published just a couple of months ago. In that meta-analysis, we found that in individuals with aortic stenosis, those who had the highest LPA levels, actually you saw their progression of aortic stenosis be 40% higher compared to individuals with low LPA levels. And interestingly, there is a trial that's ongoing, and we are recruiting individuals at our institution to test the effect of an LPA lowering drug called pelacarsen on the progression of calcific aortic valve stenosis. So the study has just begun the randomization process, and it's going to take 3 years to do that trial. So this is a small trial that will have about 500 individuals, but this will be interesting to see if we lower LPA, do we lower the progression of aortic valve stenosis using echocardiography and computed tomography. So these will be imaging based trials. So what about outcomes? Of course, imaging is fine, but it doesn't tell you if you're gonna necessarily require an aortic valve replacement, or if you'll have a heart attack or a stroke or a cardiac death. So we were interested in, so this is actually some data that's not published from our group. And what we're trying to do here is to document in patients with aortic stenosis in the UK Biobank, whether LPA in these patients is actually linked to the future risk of aortic valve replacement or cardiac events. And we saw that in individuals with high LPA, so there's approximately 2,000 individuals in that UK Biobank analysis that have calcific aortic valve stenosis. Those that have high LPA are at 58% higher risk of having future aortic valve replacement. And if we look at a combined endpoint of aortic valve replacement and cardiac death, the risk is 43% higher. The risk is 36% higher if we look at the composite endpoint of aortic valve replacement and major cardiovascular events risk, such as non-fatal MI and non-fatal or fatal stroke. So basically, this is what we're trying to figure out right now in my lab. We're trying to see if LPA is linked with poorer outcomes in patients who undergo aortic valve replacement. So after the valve is replaced, does LPA still contributes to aortic valve degeneration? Is screening for high LPA and treating high LPA cost-effective in patients with calcific aortic valve stenosis? Is it helpful? And obviously, we're going to need some trials to document in patients with CAVS. Does reducing LPA levels reduce disease progression with imaging? And does it ultimately lead to better valvular and cardiovascular outcomes? So with that, basically, I'd like to just to summarize. I think this is a nice summary. This is the data from this is the summary figure from the European Atherosclerosis Society consensus statement on LPA. So basically, we put forward the notion that LPA should be measured at least once in adults, that the interpretation of LPA concentration should be done in the context of absolute global cardiovascular disease risk, that intensified risk factor management by lifestyle modification and medication is very important, and we're very eager to see the results of the phase 2 and 3 trials that are testing the hypothesis that LPA lowering will actually be associated with fewer cardiovascular outcomes in patients with established heart attacks. So I hope I've convinced you that we should that there's something that needs to be done about high LPA. And if you're not convinced, then let me tell you, and this will be my final slide, about these 8 reasons why LPA should be measured in everyone at least once in a lifetime. So first, to identify individuals who are at very high genetic risk of ASCVD, to ensure timely implementation of new treatments targeting high LPA to prevent ASCVD, to identify individuals who may benefit from earlier and more aggressive management of a conventional risk factor. I haven't talked about LPA assays, but I think it's safe to say that contemporary assays do identify individuals with very high LPA levels. That measuring LPA level is a low-cost way of identifying individuals at high risk of ASCVD, to prevent cardiovascular events in families at high genetic risk of CVD, and most importantly, I think to provide answers to patients who develop cardiovascular disease despite having 0 or very few conventional risk factors. So with that, I would like to thank you very much for your attention. Thanks again for the very kind invitation, and I look forward to your questions.